In May 2018, the Department of Veterans Affairs signed a 10-year contract with Cerner, later Oracle Health, to overhaul its electronic health record. The legacy system VistA had served millions of veterans since the 1980s, but had splintered into dozens of facility-specific customizations. The promise was a single, seamless platform linking VA care with the Department of Defense. It was one of the largest health IT projects in U.S. history. The contract was structured to eventually integrate with the military's health system, creating a lifelong digital record for service members. But by early 2023, that ambition had come to a grinding halt. The first 5 medical centers went live between 2020 and 2022. Almost immediately, red flags appeared. In 2022, OIG inspectors visited VA Southern Oregon and the Wainwright VA in Washington. Leaders there described the new EHR as the single largest challenge they had ever faced, rewriting the way VA does business. They cited inadequate training, poor timing overlapping with pandemic recovery, and communication breakdowns that left staff unprepared. Productivity losses, financial strain, and patient safety concerns were reported across both facilities. It was a quiet crisis unfolding in real time. In September 2024, the OIG released an audit that deepened the alarm. Since go live, the new EHR had experienced hundreds of major performance incidents at the 5 initial sites. System changes were causing failures that neither the VA nor Oracle Health could control. According to the audit, there were no adequate protocols to prevent changes from breaking the system, no uniform incident response, and no interoperable downtime equipment. When the EHR went down, clinicians were left to improvise. The report noted that while major incidents could delay care, the VA had no formal process to link those delays to specific system failures. When an EHR goes down in a hospital, the effects ripple through every department. Yet the OIG discovered that the VA had no centralized way to connect major incidents to reports of delayed care. Patient safety risks remained unquantified and unaddressed. At the Lovell Federal Healthcare Center, documentation flaws in interface testing raised questions about whether critical financial and clinical connections were thoroughly validated before go-live. While the OIG confirmed that the correct tests were eventually performed, the administrative gaps undermined confidence in the deployment process. Without real-time data sharing, the VA was flying blind. By 2023, the Government Accountability Office had issued 18 recommendations aimed at fixing cost estimating, schedule, program management, and user adoption. The GAO reported widespread user dissatisfaction, and the VA had not adequately addressed it. Congressional committees demanded a detailed cost estimate and schedule by September 30, 2025. When the deadline passed, the VA had provided only a notional schedule, no concrete numbers. In December 2025, GAO Director Carol Harris testified that critical actions were still needed. The program was essentially flying blind, and lawmakers were losing patience. 2 priority recommendations on cost and schedule remained open, leaving the program's future in limbo. In April 2023, VA Secretary Denise McDonough announced a program-wide reset. No new facilities would go live until the system demonstrated sustained improvements in clinician experience, system reliability, and productivity. The announcement was a tacit admission that the rollout had been premature. The VA pledged to focus on fixing the foundation before expanding. This was not a cancellation, it was a strategic pause designed to prevent further damage. But for veterans and VA staff, the question remained: how long would the pause last, and at what cost? The reset criteria included high performance and high reliability, goals the system had yet to meet. By March 2025, the GAO reported some progress at the 5 initial sites. Workarounds had been implemented, and certain performance metrics improved, but these fixes came at a cost. The department's actions to address the challenges had impacted the program's total cost estimate and schedule. The GAO made 2 urgent recommendations: update the cost and schedule to reflect reality. Without these, future planning was guesswork. Clinicians had spent years adapting, and many still felt the system was imposed on them rather than designed with them. User satisfaction remained a concern, and the heavy reliance on manual workarounds was unsustainable at scale. As of late 2025, the VA had not provided a detailed cost estimate to Congress. The notional schedule was high-level and lacked the rigor required for oversight. With the original 10-year contract ticking and more than $5 billion already spent, the path to a nationwide rollout was murky. The reset had stopped the bleeding, but it hadn't healed the wound. New deployments remained on indefinite hold, and the VA's budget requests met skepticism on Capitol Hill. The vacuum of information left Congress and the public in the dark. How much more would it cost? When would the next site go live? With 170 medical centers waiting, the lack of answers turned the EHR modernization into a symbol of project management failure. The VA's experience is not just a story of a troubled IT contract. It's a lesson in what happens when system integration, training, and governance are treated as afterthoughts. The legacy VistA system had been deeply embedded in clinical workflows. Replacing it required not just new software, but a fundamental rethinking of how care is delivered. The OIG and GAO reports consistently pointed to a lack of frontline engagement in design and testing. Clinicians felt the new system was developed by people who had never worked in a VA hospital. No amount of executive mandate could force a system to work if the people using it were not on board. Change management experts often say that successful digital transformations are 20% technology and 80% people and process. The VA flipped that ratio. VistA was once hailed as a model of health IT innovation, but over decades it morphed into a web of incompatible versions because each facility modified it to suit local needs. The new Oracle system was meant to impose uniformity. That uniformity clashed with the reality of 170 different hospital cultures. The tension between centralization and customization is common in large organizations. The VA's mistake was not in seeking standardization, but in underestimating the depth of local adaptation. One OIG inspection noted that the new EHR impacted every system and rewrote the way VA does business, without sufficient local input. A one-size-fits-all solution ended up fitting no one. The VA's electronic health record modernization offers a textbook case for what not to do. First, user readiness must be proven, not assumed. Second, system reliability cannot be gambled on. Major incidents must be rare and recoverable. Third, cost and schedule transparency are not optional. They are the bedrock of accountability. The GAO's 18 recommendations read like a map of avoidable pitfalls. Above all, the project demonstrates that governance structures must be robust enough to catch problems early. The OIG, GAO, and Congress eventually forced a reset, but by then hundreds of millions had been spent and patient safety had been put at risk. Pausing a project is cheaper than pushing a broken system onto users who will reject it. The VA's EHR reset continues. 5 sites operate the new Oracle system under heavy workarounds, while 175 others wait. The promise of a seamless modern health record for the nation's veterans remains unfulfilled. The project is not dead, but it is on life support. As the GAO and OIG reports make clear, until the fundamentals of cost, schedule, safety, and user satisfaction are addressed, the restart button cannot be pressed with confidence. The stakes couldn't be higher. Every day of delay affects veteran care, but the alternative, rushing a flawed system into more hospitals, is unthinkable. In the high-stakes world of hospital IT, a system that isn't ready can do more harm than no system at all.